Why did I come from Australia to this? So basically, I suppose my objective is to try and see how we can look after transplantation patients better, and I think that's going to be with precision medicine. That's not going to be done by any one centre, and I think getting an international collaborative of like-minded people together is important. And so I was excited to hear from Paul Keown when he talked about your initiatives with Genome Canada here to bring that to transplantation. So I thought it'd be a great opportunity for me and come and learn what you guys are doing and see how we can work together to get this over the line. So before I start, I'd like to go through my disclosures, and the most important disclosure I have there is that I'm not a bioinformatician. I've learned how to spell that word, but basically that's not what my skill set is. I work with people who are big in bioinformatics. I've done a lot of clinical transplant research. I understand the biology and the mechanisms of disease, and I think you need to get those two people or those two skill sets together to make an impact in this area. I will put up my acknowledgement slide now because it does have people who did a lot of work, and you can see a lot of the work here was a collaboration between Westmead and Mount Sinai in New York. And the person who really led the bioinformatics in that was a guy called Wei Zhang, and especially in the deep learning and AI for looking at transplant biopsies. The other person I did want to acknowledge there was Karen Keung. She's now a trained nephrologist and was a trainee with us and did a PhD and spent half the time in my lab and in Barbara Murphy's lab in Mount Sinai, and has done a lot of the work, the hard work in getting a lot of this over the line. So why are we doing this? So what's wrong with what we've been doing? Because basically my whole time in clinical transplantation, or at least 3/4 of it, we've done the same thing, which is you give induction, maybe depleting or non-depleting tacrolimus, mycophenolate, and prednisone. And if you look here at this slide from ANS data and the Australian data, that if you look at survival after the first year, that the slope of the line hasn't changed. I've been showing this slide for about 20 years. I update it about every 5 years. And depressingly, the slope of the line doesn't change. So if we're going to make improvements in people's lives, we're not going to do it by doing 1-year clinical trials, because at 1 year, the results are good. We've got greater than 90% patient and graft survival. However, once you get out to 5 and 10 years, that's when things go badly. And if you've got someone who's 30 or 40 with end-stage renal failure and gets a kidney graft, has got a family, that's not a good time. The other thing is that if you look at death as a cause of with graft function or death soon after it, that's quite remains high. And people with a failing graft have 7 times the death rate of people who have good graft function, and it's even higher than people who are on dialysis. So we still have a problem with death with function. Also, if you look at this is again, they're small numbers, but it's the latest data from ANS data, that cancer and infection, which are largely related to immunosuppression, the death rates from that remain stubbornly high. And it's always a battle who's going to win the pop chart there, whether we're going to get more death from infection or more death from cancer. So there are a lot of people who've got good graft function, but we're killing them with immunosuppression. And if you look at the causes of graft loss, it's still some form of rejection, be it chronic or acute. So we know what people, why grafts are failing, and we know why people are dying, but we need to be more selective and we need to think in a more intelligent way about how we're going to treat people. And we need to bring new drugs into this mechanism, and we can't just keep doing old clinical trials. So we have to rethink how we look at this situation. So this is it's an old article now, but by Willis and Lord, but I recommend people read it because it's a really succinct description of where we are and where we need to go. So I don't know if this works. Does people see this up on the screen? So basically, this is where we are now. It's what I call herd medicine. We yard all the animals into the, or all the patients into the yards, and and we all give them the same thing, regardless of what they do. Okay, we look at predictive things. We might give a depleting antibody. We might give more tacrolimus to people at high risk. People at low risk, we give less. But basically, we're playing around the edges. What we need to do now is really move to this here. So this is this intermediary step between empirical medicine and personalised medicine. And that's where we can at least categorise people into high risk, intermediate risk and low risk. We can then do clinical trials in those areas. We can have much more bespoke immunosuppression, look at completely different agents that we're using now for specific groups of patients, and study mechanisms within those groups. So I think that's where we need to get to from where we are now. The other thing is that graft loss and graft injury is very complex. So this is a slide I've been using, and you can see there's a lot of factors that go into this. We've got donor factors, we've got recipient factors prior to transplantation. We've got issues such as ischemia from deceased organ donation, acute rejection, subclinical rejection, calcineurin toxicity, chronic antibody-mediated rejection, and all the comorbidities such as hypertension, diabetes, and hyperlipidemia. But at the moment, we know that it's not until we get glomerulosclerosis that we start seeing a rise in creatinine. So people who turn up to our clinic and people who turned up to my clinic, you can be quite deluded about how well things are going for some years before creatinine rises. And by the time you get out to this part of the transplant care, you've missed the boat. That you're trying to plug a hole in the Titanic after it's hit the iceberg rather than trying to avoid that. So Brian Nankivell, in his study of protocol biopsies, showed that with histology you can get earlier predictions, and also I think therefore with genes we can get earlier predictions again, and at a time when you can probably do something about it for the patient, not at a time when it's all bad news. So in the study, what I want to do is go through some of the things, the tools we're using, and some of the examples of how this has helped. So I think I want to stress the importance of patient cohorts and biorepositories. I think there are opportunities for predictive biomarkers to stratify patients for clinical trials, and I want to show examples of the impact of AI and machine learning on transplantation in precision medicine. So I like to think about this. If you're looking after a patient, there are certain times when you can make some important decisions in their care. So the first is the day they come in to get their transplant, or in that pre-transplant period. So there's a lot of things going on. There's the recipient immune status, there's the pathology of the graft, whether it's a living or deceased donor. And we do some of that. So we do look for donor-specific antibodies. We do know people who've had a highly sensitized, or people who've had a prior graft and had bad outcomes. And we do make decisions based on those things. But I think there's a lot more information we can get from patients that can help you categorize patients, especially those who are coming up for their first transplant who don't have donor-specific antibodies, and say, are they in a high or low or intermediate risk? The next 6 months are important, and that's really a period where there's the risk of rejection, both a cellular and antibody-mediated rejection. So close monitoring, identifying people at risk prior to rejection would be an important objective. And then there's this really difficult group, is what we do after the first year, because actually, if you look at people, and there's plenty of data around this, if people who lose their graft at 5 years, between 5 and 10 years, 30 or 40% of those have excellent function and a good graft at 12 months. So I think we need to be able to have a better idea who's going to at risk of losing their graft in the first 5 years, or 1 to 5 year period. And we haven't done that well. It's really difficult to do clinical trials in that group of patients. So if we look about how we're going to do this, we need to look at patient cohorts. So basically in this I'm talking about two cohorts, and the main of the data I'm going to show you is called the GOCAR study, and you'll see that on the next slide. But I thought I'd just identify the cohort we've been collecting that started after the GOCAR study, which we're involved in. And basically, we've got roughly about 300 patients. So these are prospectively collected. People enter the study and they agree to have, at the time of protocol biopsy, which we do at 0, 3 and 12 months in all patients, they agree to have an additional core taken for RNA. We collect DNA, we collect blood for RNA at those same time points, as well as putting away lymphocytes and urine. And this is then put away in an extensive biorepository. So over time, we've got about 300 people in that group now. It's got linked clinical data. And after a while, you then get quite a lot of a very well characterized and curated group of patients where you can look at both, you can link histology, clinical outcomes, genomics, both in the graft and in the peripheral blood, and also look at SNP studies. You can then have a group that you can collaborate with in a meaningful way and bring some real power to those studies if you get 3 or 4 centres around the world that's got the same number of grafts. So in a small niche field, you can get economies of scale if you work together. So this was the GOCAR study that was led by Barbara Murphy, and it was, again, it was a collaborative study between 5 centres, 4 from the US and Westmead. The most of those that had protocol biopsies were done either at Westmead or at Mount Sinai. And for the purposes of what I'm going to show you here, which was looking at that third group, so those looking at what are the risk of chronic graft loss, there was about 204 patients where they'd had a 3-month protocol biopsy, and they divided into 2 cohorts where they had a biopsy core at 3 months for what was then microarray. So this was before RNA-seq. And they'd also had a corresponding 12-month protocol biopsy. So by the time you had people who dropped out along the way for that, we had about 100 patients. And what we were looking at is those who went from 3 to 12 months and their clinical course was stable, and those who had progressive fibrosis was a marker of chronic damage. And for mathematical reasons, we chose the CADI score rather than the BAMP criteria, although we have validated this in BAMP. And we were looking for a predictive gene set. So basically, what Wager did was a quite extensive analysis of the genes. So the problem is when you get to extensive arrays or RNA-seq, you've got thousands or tens of thousands of genes, and it's not really useful in trying to work out what's going on. So they did the correlation analysis, and they were looking for people to look at what was CADI at 3 months. So knows what gave you a bad CADI score at 3 months, but also what in the 3 months protocol biopsy gave you a bad CADI score at 12 months. And then they were able to take that data, and then what they wanted to do was to look at those genes that weren't there that didn't predict 3 months but did predict 12. So in other words, they were people. We were specifically looking for something in a 3-month biopsy that was going to predict a poor outcome, but not necessarily 3 months. And then they took that gene set, which that gave them about 150 genes, and then they took that gene and they did various randomizations to get it down to about 150. Like they would divide the group randomly into 2 different groups, and then redo the correlation analysis and look at the genes, and they'd repeat that about 1,000 times, about 100 times, until they then got a gene set of about 100 or 150. They then were able to randomly select 20 genes and then see if you use those 20 genes and looked at their AUC, how good was that predicting 12 months, and then they repeated that estimate about 1,000 times until they came up to a gene set of about 13 genes, which was found to be highly predictive by a combination of these randomized tests. They then wanted to make sure there was not overfitting, and they did a lot of analysis of that, including random allocation of CADI scores to patients, to gene scores, and doing that doing thousands of times and looking to see which gave you the best AUC. And the 13 gene sets still gave the best AUC. And then they looked at validation, both internal and external validation cohorts. So for me, this was quite an insightful way of getting a lot of genetic data and bringing it down to something that was meaningful. So if you looked at the analysis, so if you looked at when they did the differential gene expression with using a Spearman correlation, you could see that there were genes that identified 3 months CADI and 12 months. So there was a group that identified that were common to both, but there are also genes, and quite a large number of genes, that were predictive only of 3 months or only of 12 months. And as expected, if you're looking at 3 months scores, that a lot of the genes that you saw were related to T cell or immune activation. And I guess that's what you'd expect. And those that were common to both, again, had a strong area of immune activation with some cell differentiation, but only the ones that were predictive of 12 months were not immune related, but around tissue remodeling and markers of tissue injury. So the genes that you were seeing that was evolved in 12 months were more a signal of graft injury rather than an immune response. And when they did using the genes to identify cell subtypes, they said in the 3 months ones, the predictive predominant cell type based on the gene expression were dendritic cells, but those that were predictive of 12 months, the most predominant set were stromal cells. Though there were also strong markers from macrophages remaining dendritic cells and CD4 cells. And these white genes are the genes that were in our 13 gene set, and you could see it related to either macrophages or the stromal cells. So this was the 13 gene set. As I said, it was more a marker of cell injury. So, and it was perplexing. So when you pull up this, that I didn't see any of my favorite genes on this. So it was, we sort of had to go back and learn a few things. But if you look at them, they are involved in cell growth, ubiquination, mesenchymal transition and fibrosis pathways. And we have done some work in trying to work out if this is involved in any way directly in mechanism, or how are these genes involved in mechanism. So how predictive was it? It was very predictive. So if you look at the top left, that you could see it was highly predictive in the set we trained it on, and much more predictive than clinical indicators or clinical indicators plus histology. If we looked at an internal validation set, it was still highly predictive. And two external publicly available data sets, again, it remained highly predictive. And it was also, if you looked at fibrosis at 12 or 24 months, you looked at GFR or BAMF scores, again, it was highly predictive of progressive deterioration. We then, using a principal component analysis, identified Wager put a way of developing what he called a gene risk score, which was the weighting of the gene score, and looking with the outcome being graft loss. And if you had a high risk score, you had significantly worse graft outcomes. So you could see that using a combination of AI and gene and those 13 gene expressions, you can identify those who've got a higher risk of graft loss, both from our data set and also the data set from the one available public data set that was predictive of this. So you can predict graft house loss at 3 months looking at the biopsies. And these biopsies were generally good biopsies. So if you excluded those that had any subclinical rejection or those who had really high CADI scores or BAMF scores, the outcome was still the same. So that's looking at one end. So what happens if we then go back to the other end and then looking at prior to transplantation? So it would be nice to know when someone asks you, as they always do, how do you think this is going to go, to have a bit more information than we currently do. And so using the same AI and machine learning techniques, they were then looking for the transcripts prior to transplantation. So this is before these patients had received a graft, and they were then looking at the outcome, which was early acute rejection in the first 6 months. And so what was interesting was in those who had a greater risk of rejection, that they had a downregulation of IL-12 genes. They had a downregulation of genes associated with NK cell cytotoxicity and an upregulation in collagen and sort of monocytes and macrophages. So this is the data. So this is looking in the serum of these patients that IL-12p40 was reduced in those that had in the group that had early acute rejection compared to those that did not. There was an upregulation of genes associated with neutrophils and monocytes, and a downregulation of genes associated with NK cells, CD8 T cells, and NKT cells, which is probably not what you would think, but is consistent with data in autoimmunity and lupus. So if we looked at this, that it was predicted, that you could see there were two interesting things about this. One was that that if you had developed a gene risk score based on a 23 gene set, which was calculated based on the similar way we predicted that for the original paper, you can see that higher scores are associated with acute rejection. It wasn't very good at detecting subclinical rejection. And high risk scores had a worse graft outcome at 3 and 5 years. And this was reasonably predictive. So again, you could say that pre-transplant, you can identify patients that would be at higher risk, and maybe you could stratify these into high and low risk for future clinical trials. Using 3 months post-transplant blood rather than biopsies, they developed a 17 gene set, which was predictive of acute rejection. So its positive predictive value was not as high as the other assays, so it did have a high negative predictive value, which is important, I think. And this is the gene set. And the thing here that if you looked at graft survival based on whether you had a low risk or a high and intermediate risk, then you could see those with a high risk had a greater graft loss than those with a low risk. So with this assay, if you had subclinical rejection, you could detect that, and you're either in the intermediate or the high risk group. We don't know if it's suitable for antibody-mediated rejection, because in this cohort, only one patient had antibody-mediated rejection beyond 3 months. The other 9 or 10 patients who had that prior to this assay being done, so it was a priori. But again, you can see that we've been able to identify a series of predictive biomarkers that can use at different times in transplantation that could help us stratify the patients. So what I didn't highlight in the first one, we looked at the pre-transplant blood, that assay was much more predictive if you had less than 4 HLA mismatches. So if you had 5 or 6, if you had a highly mismatched graft, the predictive value was not as strong as if you had 4 or less. So there are other data we can use that can help that prediction. And one of the things that Wage has done, and certainly this was really a tour de force by him, was trying to look at a better way of looking at the graft histology in a real world type setting by using deep learning and scanning the biopsy to then give you an outcome. So basically what he did, he used two AI processes called CNN, which is convolutional neural networks, and UNet. So what he did with this regional convolutional neural network process was he was able to identify tubule cells. He was able to identify glomeruli, blood vessels, and mononuclear cells as individual things. And then he could predictively do that, and he could do that for the whole core of the biopsy. He was then able, with UNet, to look at that in a whole segmental area to work out what was the area of fibrosis and what percentage of these areas were mononuclear or what was tubulitis. So he was able to look at tubular features which were normal and abnormal, the leukocyte infiltrate and an interstitial score, and then he called it what was a whole slide sort of information. So he was able to scan the whole slide and give it for the whole cohort. So this was then he sort of trained this on the GO-CAR cohort of 400 patients, and then it was validated on the OSCAD cohort and looking for slide-wide features, and then correlated it with BAMF score and then with graft survival. So this is sort of looking at the input image. This is, you can see the graft. You do an outline of the core. You can see here what are tubules and abnormal tubules and an interstitial space and mononuclear cell infiltrate. And you can look at various regions of interest and then map those regions of interest to cover the whole graft. So when you correlate this with BAMF scores, so it certainly correlated with the CI score and the CT score, and also the G score. So in other words, there is a correlation. It's not just voodooism. It does work well, but it takes out the human error. It also takes out the situation that often when these things are done, it might be in the middle of the night. You're not going to get an expert pathologist reading that biopsy. And what we're able to see, so basically we looked at time zero biopsies and 12-month biopsies, and you could see that in the time zero, so this is the implantation biopsy, that we had what was called the baseline interstitial and tubular abnormality score, and the scanning was better at picking the areas of interstitial fibrosis, of tubular atrophy, and the combined score was more effective. It was predictive at 1 year at a CI/CT score, and was more predictive than BAMF. However, beyond that, it lost its predictive availability. So, and it did predict, you could use this score to identify people who were at risk of losing their graft at 1 year. The 12-month score, which was done on similar techniques, was more predictive, and he could see that if you looked at the 12 months at the INT scores, that the chronic damage score was more predictive at 2 year, 3 year, 4 year graft loss. So it gave better outcomes for graft loss, and it was much better than clinical predictors. And this is identifying that you could identify people who were going to lose their graft out beyond 5 years. So, so if you think if we can combine that with those gene scores, you're adding donor and recipient data, and this needs more refinement. And then there's epitopes and other things. I know it's going to be speaking today. We are now starting to get an array of tools, which we now need to see how can we organise this in a cohesive way to give us more information about patient outcomes. So I do want to just sort of start giving those examples and start summing up. So I think one thing is we've felt at Westmead is that it's the damage you don't see that's really a major cause of progressive fibrosis in that first year after transplantation. shown that, and I know Peter Nickerson and people at Winnipeg have shown that in protocol biopsies. And I now think we've got a suite of transcriptomic and AI tools that are being developed that are more accurate, can give us a more accurate determination of risk. And so there are pre-transplant predictors. We can look using the biopsy in a more effective way for tubular and interstitial injury, predictors of acute rejection, and predictors of fibrosis and a graft risk score. So I think we can use these. We should be thinking now, how can we use these as enrichment strategies for clinical trials in the first instance? Because at the moment, what we don't have is a smart way of doing that. And this is really what I think is going to lead to better precision medicine and transplant management. So I think we can take a leaf out of the oncology book. And this is sort of an alteration of a slide by Friedland. And they've got a lot of drugs coming to the market for cancer by using surrogate endpoints that predict hard endpoints, that you can have a biomarker that you can put into enrichment so that you can take those who are positive or negative, randomize those against, and have a trial for standard of care against treatment B, as I call it. And those who are negative or those who are low risk, again, you could have a different trial, and maybe you could try immunosuppressive minimization. So I think that's ways we could move forward. So I'd just like to finish up by saying, what do we need? I think we need large, well-curated patient cohorts with linked biorepositories and linked to the EMR. I think we definitely need bioinformaticians and clinicians working in teams. It's a rare beast that's got the clinical understanding, the biological understanding, and the mathematics to do all this. That's my experience anyway. I certainly don't have the mathematics. And I think we need to think of a process of where we come together as a group and say, what are we going to take, which of these markers we're going to use for using clinical trials, and how are we going to commercialize these, and how are we going to work with industry to look at a new way of doing clinical trials here. And we need new clinical trial formats, that's for sure. So I think the adaptive clinical trial will get greater traction. And I think the nature of transplantation, we need to work internationally and in groups internationally and get international collaboration, because we're not going to get the thousands of patients we need by doing that. I mean, Australia's like Canada in many ways, but basically we're 25, 30 million people. It's just not enough. So happy to leave it there and happy to answer any questions.
So has anyone got any questions? Are there some questions online?
Yeah.
Too close. All right. Hi there. Excellent talk. I think it's a great overview of the challenges in transplant. One thing that I felt was a bit contradictory in what you presented, right? At the beginning, you start by saying that our first year or early outcomes have gotten better, and that's where the improvement has come in. And the late outcomes have not changed. But then most of the studies, if not all the studies you showed, all look at the early markers and early biomarkers and early treatments. Maybe the penultimate slide is kind of what the answer is. But how can we change things to actually improve the long-term outcomes if we're only looking at the early period?
Well, yeah, I think that's a good question, and it is complex. So my way I look at it is that if you still look at people who have rejection or people who have subacute alloimmune injury, often which is not classified as BAMF1A rejection, it might be borderline, that these people tend to have chronic grumbling processes. And if you look at 12 months, the hard outcome of graft surviving, patient alive are good. But really, there's a group of those patients who are on the wrong path, and at 5 years, they're not going to be good. So I guess what I'm trying to say is using the traditional markers we've used for clinical trials over many years of a graft outcome at 1 year, at 12 months, or even at 2 years, that they're too blunt a tool to work out who's going to do well 5 or 10 years out. So, I mean, patients are grateful that they're doing well at 12 months, but they're pretty disappointed if you said, well, you're going to get less than 5 years survival. Like, I guess if patients have cancer, they want more than 5 years survival. So I think, and I guess there's a bit of presumption that what's happening in that first year is going to be very influential on those outcomes beyond 12 months. You know, that's I guess what I'm trying to say, and I guess that is a presumption. I haven't, until we do the studies, we haven't got the proof.
Are there any other questions? Oh, yeah.
Do I need to press it again? Here.
Yeah, there we go. Hi, thank you for the talk. So I actually come not from a clinical background, I come from a research background. So I've actually just got a question about the MRCNN software. So it's like the AI neural network software. Yeah. So is that a software that's like publicly available? Is that something?
Yeah, there's a thing called, I think it's been set up to look at pathology, and if you go to the paper in the supplementary, if you go to the supplementary information, they'll have it at something like, pathology something dot such and such. But didn't use that. But I think these are publicly available tools.
But could that be used on so like transplantation? But could that be used on like cancer biopsies, or could that be more globally? Yeah.
I think what Wager did was took tools that have been used for other forms of pathology and just adapted it to transplant. So he didn't devise this from nothing. He used tools. It was more an adaptation rather than devising something de novo.
Yeah, I think tools like that could be, you mentioned, right, not needing a pathologist to then look at that biopsy, could use software in the middle of the night. How far do you think something using like a software like that could be like from being used in the clinic?
I guess really that'd be a question for Wager, and I'm sure he'd answer it for you, or I'm happy to ask him. But basically, I think there's more refinement needed for it to go ahead, and then you need to put it into a sort of a commercial package so that you can either put it up in the cloud somewhere and people can access that.
For sure.
Rather than so that takes a bit more finesse than having someone who's if you're going to Wager's office, he's got 5 screens. He doesn't need the heating on because the computer generating so much heat doing all this stuff. So basically, to go from there to a tool where you put the slide in and hit the button, I think that can do. But that's really what software engineering do. If it's thought to be important enough, that's what they'll do. They'll invent that type of process.
Thank you.
Thank you.